Hello and welcome, everybody. My name is Jörn Schattenberg. I'm the director of the Metabolic Liver Research Program at the University Medical Center in Mainz, Germany. It's my pleasure to welcome you today to this short webinar, Pan-NASH Initiative, on our recent article featuring multi-stakeholder approaches in NAFLD care. So the multi-stakeholder approach as an innovation in NAFLD care. Why is this required? Here are my disclosures. As you all know or are mostly aware, non-alcoholic fatty liver disease is a disease continuum. Constitutes different disease stages, and it's defined by histological changes in the liver tissue, depending on the stage and the grade of the disease. You can have early disease, lots of fat, a little bit of inflammation, a little bit of fibrosis in the liver. And it's the advanced disease stages and the cirrhotic stages, F3 and F4, that really concern the hepatologists and myself, because they lead to decompensation and hepatocellular carcinoma. The incidence of hepatic complications related to NASH is expected to increase significantly due to the unbroken endemic of obesity and type 2 diabetes. Those constitute independent risk factors for advanced liver disease, and we will have to find solutions to address this growing burden of liver disease. Now, liver disease does not exist in isolation. Patients that do suffer from, in particular, advanced disease stages typically are comorbid with obesity and type 2 diabetes as the major risk factors, but also cardiovascular disease, arterial hypertension, closely being linked to the pathophysiology that drives the organ injury in NAFLD. Diabetes, 75% of patients living with type 2 diabetes exhibit NAFLD. So if you're tending or providing care to patients with type 2 diabetes, you should start screening for advanced liver disease, and you'll be surprised to find 10 to 15% of your patients already exhibiting cirrhosis in a compensated stage, which you're not aware of based on normal blood function tests. Of course, this also hampers the glycemic control, and you might think about the patients that you have difficulties to optimal control in their A1C. These are the ones that could, in particular, already have advanced liver disease. From that constellation, severity of the disease in the liver, multimorbidity, it already becomes clear and obvious that we need multiple stakeholders to provide care to these patients. Here's some data we explored in the German system. You can see that patients with NAFLD, this is the blue line, and patients without NAFLD, this is the red line, do have a significant difference in terms of the incidence of cardiovascular disease over time. This is not the only or major contributor, but it's an independent contributor. And we hope that by controlling fatty liver disease, potentially treating it with medical therapeutics in the future will also decrease that increased risk in this population again. Now, there's also a lot of drugs that are used to treat or prevent cardiovascular disease. Some have shown limited benefit in NAFLD. I'm going to be discussing this a little bit later. From the public health approach, it's very important we raise the question, where are these patients and how can we identify them? The actions must focus around a disease that is asymptomatic, and the acknowledgement by many people and colleagues is pretty low. So one of the major tasks is to actually raise awareness and educate patients and peers, allow for personalized approaches, and define clinical referral pathways in which these patients can be provided best practice care. So what is needed? Currently, we don't have therapies. However, there are effective measures that also prevent cirrhosis and HCC most likely. And as such, even today, the clear questions and the 7 questions that we formulated are: who provides the care today? When and how often are these patients seen? What care must be provided? And how do we have to consider the disease stage in this context? In which healthcare setting is the care provided? Is this primary care? Is this secondary care? Does it need a hepatologist? And if there's no access to a hepatologist, how can we bridge that gap to provide care? To what extent is care coordinated across the healthcare systems? And I can tell you from the German system, there are certain mechanisms under which this could work, but I would like to say that for non-alcoholic fatty liver disease, this is not current practice, and there is a big gap we need to fill. The priorities for healthcare providers and policymakers are, of course, also to optimize these gaps, because occurring cirrhosis and hepatocellular carcinoma has a high burden both for patients but also for the socioeconomic costs. As NAFLD, as I've just shown you, is a multi-system chronic liver disease, prevention and management across multiple disciplines is important. Now, we could do this bottom up, starting with the primary care and the physician, to develop efficient models of care. And I think this is a very promising approach. I'll show you in the end. We're going to be having the Innovations in NAFLD Care meeting in Barcelona, end of May. Feel free to sign up if you're interested in this. There's going to be a great discussion with faculty and participants to improve and develop these models of care. But you could also argue that it needs to be top down, and we need the guidance of the national and the global strategies that inform the physicians and define the imminent steps that have to be taken. At present, again, and as I said before, lifestyle intervention is the keystone in management in these patients, but there is focus on drug development. And the drug development process currently looks at drugs that provide a holistic treatment approach for metabolic disease, for example, focusing on the treatment of obesity. In that context, we have to consider the degree of liver disease to potentially select the right drug in patients when there is an indication for a drug in type 2 diabetes and a patient has advanced disease, to choose the right drug to also treat fatty liver at the same time. This is not as easy today because, again, there's limited therapeutics available and limited data. But in the future, I think we must be asking the question, how severe is the liver disease, to be able to provide the best care for patients living with type 2 diabetes, in particular if they exhibit advanced disease stage. As a take-home message, I think both the American as well as the European guidelines are recommending multi-step approaches to identify these patients using a simple test that has a high accuracy in ruling out advanced disease stages. The limitation is that these tests are not good in identifying patients with disease, so a second test that has a higher specificity is required, and the identification of patients with advanced disease based on that will help us to eventually provide care. Weight loss, clearly the cornerstone today, but emerging evidence, for example, for medical treatments are also available. Let me finish and also send a invite again for you to sign up and participate in the Barcelona meeting, Innovations in NAFLD Care, end of May 2023. What is the best strategy in the absence of approved drugs? I think it's important we identify these patients, we inform the patients, we enable them to aim for lifestyle changes that have a lasting impact on liver disease, in the end aiming to prevent carcinoma, hepatocellular carcinoma, and cirrhosis decompensation, which is the major driver of healthcare costs in that patient population. And to do so, we need non-invasive tests and clear guidance how these patients should be followed up. And policymakers, I think, are needed here to recognize non-alcoholic fatty liver disease as a chronic condition and a serious disease that burdens patients' life and impacts incurring costs and expenses in the healthcare system today. So with that, thank you so much for your attention. If you're interested in this topic or similar topics, please reach out. And I'm hoping you enjoyed our short webinar here today. Thank you and goodbye.